Hello everyone, my name is Dr. HERIN Patel. I am an assistant professor in CVTS in UN Mehta Institute of Cardiology and Research Center, Ahmedabad. Today I am going to talk about the surface anatomy and its related structure which are used in the cardiac surgery. So first of all, why we need to know the surface anatomy in detail? Why? Because you need it for diagnosis, for physical examination, to hand over the colleagues, record keeping, writing letters, in fact for the understanding how the certain process work and why patients are ill and what we can do to treat the patient. For it is very important, and while being a surgeon, to know the anatomy in detail is very paramount. So I will start with the mediastinum and its division and the related structure. The mediastinum is an area between the sternum and the two pleural cavities and the posteriorly vertebral column. The division of the mediastinum is by sternal angle and the fourth vertebra. Here you can see the sternal angle. Sternal angle is also known as the angle of Lewis, which is also manubrium sternal angle, which is also known as the manubrium sternal angle. And the posteriorly the fourth vertebra, which divide the mediastinum into superior and then inferior mediastinum. This landmark is very important. Why? Because here are the structure which are located at this junction of the superior and inferior mediastinum. Most important, it's a junction of the second costosternal joint. We as a surgeon need to know the exact anatomy and the count of the ribs while doing a thoracotomy, and sternal angle is one of the landmark which we count on. It also a demarcation between the ascending aorta and the arch of the aorta. It is also demarcation between the arch and the descending thoracic aorta. It also the point where the trachea bifurcate and the level at which the primary bronchus arise. The superior mediastinum contain the important structures like arch and its arch vessels, brachiocephalic veins, right and left brachiocephalic vein, which combine and form the right superior vena cava. It also has a trachea and its bifurcation. It also has a upper lobe of thymus and also contain the lymph nodes, mainly parabronchial and tracheobronchial lymph nodes. Once we divide the mediastinum into superior and inferior mediastinum, the inferior mediastinum is also divided into three: the anterior mediastinum, the middle mediastinum and the posterior mediastinum. Here is a sagittal view in which you can see the anterior mediastinum, the middle mediastinum and the posterior mediastinum. It's another view of the same, which showing the area which are contained in the mediastinum. The anterior mediastinum contain the thymus and the few areolar lymph nodes. The middle mediastinum is the broadest of the all inferior mediastinum, which contain the heart, which contain the pericardium, the ascending aorta and the pulmonary trunk. The posterior mediastinum is the lengthiest and the narrowest part of the inferior mediastinum, which contain the descending thoracic aorta, the esophagus, the azygous system, the azygous and the hemiazygous, the bifurcation of the trachea and the bronchi, the vertebral body starting from the 4th to 12th, and the nerves which contain the sympathetic and parasympathetic and the splanchnic nerves are located in the posterior mediastinum. Now we'll talk about the heart, location and its orientation. As I said, the heart is located in the middle mediastinum. It's a pyramidal shaped structure located within the pericardium in the middle mediastinum. It is connected to the great vessel at its base. It's, if we can say, it's a invertly located pyramidal shaped structure. The apex usually lies on the superior, but now here apex is directed downward, forward and the leftward. You can see in the X-ray and the vertical line which shows the longitudinal axis of the body, and you can see the two-third of the heart lies on the left side of the midline and 1/3 of the heart lies on the right side of the midline. On the right side figure shows the blue area which has a venous return of the heart, and the right area shows the venous the arterial outflow from the left ventricle. The left ventricle arch and its vessels. The apex of the heart. Apex of the heart is formed by the left ventricle and it is directed, as I said, leftward, downward and the forward. On the surface marking the level of the fifth intercostal space just medial to the midclavicular line has a normal apex beat. Heart has a 5 surfaces. The anterior surface, which is also known as the sternocostal surface, the diaphragmatic surface, which is also known as the inferior surface, the basal surface, the posterior surface, right and the left. It has a 3 borders: right heart border, left heart border and the inferior border. On the left side you can see the sternocostal border of the heart, which is mainly formed by the right atrial appendage, 2/3 of the right ventricle and the 1/3 of the left ventricle. Here you can see the apex, which is mainly formed by the left ventricle. Here is the interventricular septum, which is a site of the septum which divide the right and the left ventricle. It is filled with the fibrofatty tissue in which runs the left anterior descending artery. The posterior surface, the base of the which is also known as the base of the surface, base of the heart, which is formed by the chiefly left atrium and the right atrium. The base of the heart extend up to the bifurcation of the main pulmonary artery and downwards up to the coronary sinus. As I said, the surface of the heart, it also has a inferior surface, which is also known as a diaphragmatic surface, which is chiefly formed by the right ventricle and it rests over the central tendon of the diaphragm. Heart has a 3 borders: right heart borders, left heart borders and the inferior border. As the name says, the right heart border is formed by the superior vena cava, the right auricle and the inferior vena cava. The left heart border is chiefly formed by the pulmonary artery, the left atrial appendage and the left ventricle, and the inferior border, which is also known as the acute margin of the right ventricle, it is chiefly formed by the right ventricle. Pericardium. Pericardium is the layer which encompasses and provides security to the heart. It is the formed by the 2 components, chiefly mainly fibrous pericardium, which is made up of thick connective tissue, and the serous pericardium. In the figure you can see the fibrous layer is made up of thick connective tissue and the serous pericardium. Serous pericardium has a 2 layer. The innermost layer is also known as the visceral pericardium and the outer layer is known as the parietal pericardium. The visceral pericardium adhere to the heart and form the outermost layer of the heart, which is also known as the epicardium. The parietal pericardium, it is adherent to the inner layer of the fibrous pericardium, and the space between the parietal and the visceral pericardium is filled with the film of the fluid which provide unadherent movement of the heart. The main function of the pericardium is to provide the stability to the heart. It provides stability, security, and also prevent the heart from the distension. It also provides friction reduction between the heart and the mediastinal structure. It also has a role to play in the limitation in the distension. Uniform distribution pericardial hydrostatic pressure. It also forms a barrier between the heart and the surrounding structure and thus limit the spread of the infection. It also facilitate in the atrial filling by providing the uniform hydrostatic pressure. Here you can see it's a MRI of the heart which shows the thin layer of the pericardium shown by the asterisk arrow. As I said, the parietal and the vessel pericardium is filled with the thin layer of fluid. So that's why it is seen as a true layer. The normal thickness of the pericardium is 2 mm, and in case like constrictive pericarditis, the thickness increases up to the 6 to 8 mm. Another picture showing the CT scan of the heart and showing the same pericardium and its layer, and you can see the innermost layer is adherent to the heart, which is barely visible. Pericardiocentesis. Pericardiocentesis is the process of aspiration of fluid from the pericardial cavity in case of cardiac tamponade and in the relief for the symptomatic patient for the pericardial effusion. This process can be diagnostic and therapeutic. Diagnostic in case of unidentified etiology of the collection of the fluid in case of neoplastic and purulent pericarditis. It can also be therapeutic in case of cardiac tamponade. Cardiac tamponade is a cardiac tamponade in which the heart is filled by the blood and produce obstruction to the inflow to the venous return. Clinically, it is marked by the back triad, which state the hypertension, the muff heart sound because of the surrounding rim of fluid inhibit the auscultatory findings, and the distension of the jugular vein because the fluid collection inhibit the inflow of the blood to the heart. And in cases like post procedure, like post PTCA, post surgery, post PPI, patient may have blood collection causing tamponade, and pericardiocentesis is one of the procedures which release the tamponade. Patient may have blood collection post traumatic, and patient may have blood collection fluid collection post infection, like in COX where patient has a massive fluid collection in the pleural cavity. Pericardial reflection. Heart has a two sinuses, chiefly transverse sinus and the oblique sinus, which is located on the base of the heart. Here you can see, if you take out the heart, then you will see the two sinuses, transverse sinuses and the oblique sinuses. Transverse sinuses is located between the great vessel of the heart and the pulmonary vein, and the oblique sinus is located below the origin of the right and left pulmonary vein. Another picture showing the same, the transverse sinuses and the oblique sinuses. The surgical importance of the transverse sinuses is that while doing surgeries like arterial switch operation, where we need to dissect the aorta and the main pulmonary artery, the transverse sinuses is dissected. Usually transverse sinuses is filled with the areolar tissue, which is dissected for the valve mobilization of the MPA and valve mobilization of the aorta. The transverse sinus is also entered while doing a PF band surgery when there is an increase or excessive blood flow to the pulmonary trunk and we need to limit the pulmonary blood flow, where we do PA banding. The oblique sinus, you can see the arrow which shows the oblique sinus, which is located below the pulmonary vein. Oblique sinus is often used while passing a C-shape retractor while looping the inferior vena cava, when we need to go on pump using a bicaval cannulation and opening of the right heart chamber. Relationship of the cardiac chambers and the great arteries. First, I would like to say the heart reaches the 50% of the atrial dimension at birth, 75% by the 5 years and the 90% by the 12 years. The differentiation between the atria and ventricle and forms the boundaries which are externally seen as a sulci. There are intraatrial sulcus, which is also known as Watterson sulcus, atrioventricular sulcus. You can see the sulcus between the right atrium and the right ventricle, which is filled with the fibrofatty tissue. Usually or normally the right coronary artery run into this atrioventricular sulcus. The interventricular surface, here you can see the sulcus between the right ventricle and the left ventricle, again which is filled with the fibrofatty tissue and in which run the left anterior descending artery. The point of junction between the atrioventricular, interatrial and the posterior interventricular groove is termed as the cardiac crux. Here you can see the posterior interventricular sulcus, which is location of the posterior descending artery, and atrioventricular junction, you can see the continuation of the right coronary artery. Crux cordis. Crux cordis is a Latin word which translates into the cross of the heart. In the figure you can see it's a crux cordis is a meeting point with the posterior atrioventricular groove, interatrial groove and interventricular groove. The right coronary artery, the circumflex artery, the posterior descending artery are meeting at this point. The PDA, posterior descending artery, again arise from this area, and the dominance of the heart is decided upon the origin of the PDA in this area. The right atrium has a three component, chiefly appendage, venous component and the vestibule. The appendage is a broad triangular pyramidal shaped structure. You can see in the picture extending from the SVC to IVC, and it is one of the major landmark identify the right heart structure. The based upon the right atrial appendage, the situs of the heart and the situs of the body is termed. Situs solidus means the right atrium located on the right side of the left atrium, and situs inversus means right heart is located left to the left atrium. The most characteristic feature of the right atrium is pectinate muscle. You see in the picture the pectinate muscle, very prominent trabeculated muscle located inside the heart in the appendage. One more thing we need to know in the right atrium is the sinus node. It's a spindle shaped structure located in the cavoatrial junction, and it is prone to injury while doing a surgery in the cavoatrial junction, chiefly doing bidirectional glantion, doing sinus venous ASD procedure, or while doing a pursing for the SVC cannulation or doing a Warden procedure. The blood supply to the sinus node comes from the nodal artery, which 60 to 80% arise from the right coronary artery, and in the rest of the cases it arises from the circumflex artery. As I said, left atrium also has chiefly three structures: the appendage, the venous part and the vestibule. The appendage of the left atrium is narrow and pointed. It looks like a crook finger. It is small compared to right atrium, and the pectinate muscle is also less prominent in the left atrium. The intraatrial groove is the site of incision while we doing surgery in the left heart, which passes just inferior to the sulcus terminalis. Sulcus terminalis is the junction between the venous part of the right atrium and the right appendage, and intraatrial groove pass parallel to sulcus terminalis and over the origin of the pulmonary vein. The incision is done parallel and over the right pulmonary vein to enter the left atrium. You can see the prominent pectinate muscle on the right side and the less formed pectinate muscle on the left side, and the shape of the appendage on the left side and the shape of appendage on the right side. Surgical incision. The most common incision and the gold standard incision is the median sternotomy. Median sternotomy provides excellent exposure to the heart and its vessels, which start from the suprasternal notch to the Ziphy sternum. Longitudinal incision is taken over the skin and skin. The subacute tissue is separated and the sternum is divided with the saw. If you after opening the sternum, this is a standard view seen from the surgeon's side. The sternal retractor are applied on the sternum edges and the sternum is separated. The pericardium is open and now you see the sternocostal surface of the heart. You see the right atrium and right appendage. Again I said it's a broad, triangular and pyramidal shaped structure. The sternocostal surface of the heart chiefly formed by the right ventricle. You can see the interventricular septum, which is a landmark between the right ventricle and the left ventricle, and the interventricular groove in which run the left interdescending artery. The inflow to the right atrium, which comes from the superior vena cava, which is formed by the union of the right and left brachiocephalic vein. Again the ascending aorta and its arch vessels. Now you see the pericardophrenic artery vein and the left and right phrenic nerve. Again another cartoon showing the same thing. The standard view from the surgeon side. The sternum retracted with the sternal retractor, the heart, the anterior border of the anterior surface of the heart and its anterior located structure. Another view showing the same thing. Here I would like to highlight the origin of the phrenic nerve, which passes very closely to the superior vena cava, and it is very prone to injury while doing a dissection over the superior vena cava, mainly while doing a sinus venous ASD closure or while doing a BDG procedure where we need to dissect the SVC higher up, so to mobilize the SVC. Here you see the thymus, which is again located over the aorta and extend up to the right ventricle. Few things about the phrenic nerves. Phrenic nerves provide the afferent and efferent fibers to the diaphragm and the pericardium and the peritoneum. It's a sole motor supply to the diaphragm, and injury to it causes diaphragmatic palsy. The right phrenic nerve descends into the thorax, and you can see it travels over the right brachiocephalic vein and superior vena cava. It descends down on the right pericardium and merge with the central tendon of the diaphragm. The left phrenic nerve again descends into the thorax. It crosses the left side of the aortic arch and the left vagus nerve. It descends over the left surface of the pericardium and it downs and merge with the central tendon of pericardium. Phrenic nerve is prone to injury while doing a dissection over the pericardium, doing dissection the superior vena cava and sometimes doing the left vena cava. It may get injured cardiac surgery in special in the pediatric population and also while doing surgery over lung and mediastinum. Other causes of injury to phrenic nerve is poliomyelitis, traumatic childbirth and radiation therapy. As I said, we need to pay attention to the origin of the right and left phrenic nerve. You can see the superior vena cava and the passage of the phrenic nerve. As I said, it may get injured while doing a bidirectional glension, sinus nephrosis ASD surgery, branch PA dissection, doing in cases like switch surgery, in surgeries like TOF with the pulmonary atresia, where we need to dissect pulmonary artery beyond its lobar branches. During that, the phrenic nerve may get injured. PDA ligation from thoracotomy, the phrenic nerve may get injured. Left superior vena cava cannulation, pericardial patch harvesting, thymectomy and pericardiectomy may also injure the phrenic nerve. Thymus. Thymus is a primary lymphoid organ. It is an encapsulated bilobal soft organ located in the superior and the anterior mediastinum, overlying the aorta and the anterior surface of the heart. It may extend superiorly up to the neck and sometimes into the inferior lobe of thyroid gland, suggestive of the common embryological origin from the third pharyngeal pouch. Inferiorly may descend up to the ascending aorta and the right atrium. Laterally it extends up to the pleura and posteriorly go up to the vessel of the superior mediastinum. The chief function of the thymus is to provide T lymphocyte to the entire body. It is also involved in the development, differentiation and the clonal expansion of the T cell response. The other incision which are used for the cardiac surgery is the anterolateral thoracotomy and the left posterolateral thoracotomy. Anterolateral thoracotomy. Anterolateral thoracotomy mainly done while doing surgery in the right heart, in the right heart of the right chambers of the heart, mainly doing AST, tricuspid valve surgery and doing the mitral valve surgery. The skin incision is begin in the fourth or fifth intercostal space from lateral border of the sternum and going extending up to the anterior axillary fold, anterior axillary line. You can see the inframammary fold is elevated, so pectoral muscle are inside, the external interior costal muscle inside and the pleural cavity is entered. Another surgery is the posterolateral thoracotomy. The standard incision follow the course of the underlying ribs and extend from the mid-spinal line up to the anterior axillary line below the tip of the scapula. It is a standard thoracotomy incision which we use in pediatric population while doing PDA ligation, in coarctation repair, in adult population doing descending thoracic surgery and BT shunt surgery in the patient with a TOF or TOF physiology who come with the who require BT shunt surgery. This is the view seen from the posterolateral thoracotomy. Here I would like to show you the nerves which run over the aorta and the pulmonary trunk. This is the left phrenic nerve which run just behind the pulmonary trunk and over the arch of the aorta, and here comes the left recurrent laryngeal nerve which encompass the ductal tissue and ascend superiorly. Here you can see the left superior intercostal vein, which is again the landmark for the PDA surgery. And now you see the arch of the aorta, the descending thoracic aorta. This is another view from the right sided posterolateral thoracoidal. Here you see the superior vena cava, the right phrenic nerve, the right internal thoracic artery, and the azygous vein, and down is seen in the pulmonary artery. This is the right posterior thoracotomy incision is used mainly for the BT shunt surgery. The coronary arteries. The right and left coronary arteries are the first branches arising from the aorta, chiefly arising from the right and left sinus of Valsalva. Now you see the right coronary artery arising from the right sinus of the Valsalva, and the left coronary artery arising from the left sinus of the Valsalva. The left coronary artery arises the main stem, and after going anteriorly and inferiorly, it divides into left anterior descending and the circumflex artery. The right coronary artery descend anteriorly and inferiorly into the right atrioventricular groove. As I said, left coronary artery arises from the main stem, coursing anteriorly and the inferiorly into the anterior interventricular groove to the apex of the heart. It has branches like diagonal, which are in 3 to 6 in numbers, and it provides numerous septal branches, and also it provides right ventricular branches. The area of supply from the left coronary artery is chiefly left ventricle, anterior 2/3 of the left ventricle septum, and anterior surface of the right ventricle. This is the left anterior descending artery providing septal branches and the diagonal branches, and it coursing toward the apex of the heart. Circumflex artery, it originates from the left main coronary artery. As I said, after originating from the main coronary artery, it descends and going posteriorly into the posterior atrioventricular groove. The main branch of the circumflex artery is the obtuse marginal artery. It provides blood supply to the myocardium, including the posterior medial papillary muscle. The right coronary artery and its branches. The right coronary artery arises from the aorta anteriorly and going into the right atrioventricular groove, taking acute margin and going posteriorly. The branches from the right coronary arteries are chiefly nodal artery, acute margin, and the posterolateral artery. The right coronary artery supplies blood to the sinus node, anterior free wall of RV, and inferior 1/3 of the ventricular septum. Kugel artery is an anatomical vessel between the proximal right coronary artery and the circumflex coronary artery. The dominance. The coronary artery gives off dominance of the coronary system is decided based upon the which coronary artery gives off the posterior interventricular branch. The right dominance, where the posterior interventricular branch is arising from the right coronary artery. It is normal in 60 to 80% of the cases. Left dominance, when it is arising from the left circumflex or the LED. In codominance, when the both artery giving branches to the left interventricular branches. Now you see the purple figure, you show the purple color showing the territory supplied by the right coronary artery, and the red color showing the territory supplied by the left sided left coronary artery. Here you see the right side dominance as the posterior interventricular artery is supplied by the right coronary artery. On the right side, you see the posterior interventricular artery is arising from the left anterior descending artery. Coronary venous anatomy. Coronary venous anatomy also we need to know for the left ventricular pacing, targeted drug therapy, delivery of the stem cell, arrhythmia ablation, and doing the retrograde cannulation for the heart. Anatomy. Coronary venous system is chiefly divided into great cardiac venous system and the lesser cardiac venous system. The great cardiac venous system include the coronary sinus and its tributaries, the vein draining into the right ventricle and the vein draining into the right atrium. And the lesser cardiac venous system chiefly are the atrioventricular small vessel, which is also known as the Thymus vein, systemic vein and its tributaries. The inflow to the heart come from the two vessels, superior vena cava and the inferior vena cava. Superior vena cava is formed by the union of the right and left brachiocephalic vein, and it drains the venous blood from the mediastinum, neck, head and the upper limb. The tributaries to the superior vena cava comes from the right and left brachiocephalic veins, mediastinal veins, esophageal veins, pericardial and the azygous venous system, which drain the small portion of the blood from the abdomen and the lower limb. The inferior vena cava retain the blood from the lower limb, pelvis and the abdomen. It is formed by the union of the common iliac veins and the tributaries from the abdomen and the pelvis. Left superior vena cava. Left superior vena cava usually not present, but when it's present in isolated cases in mainly 0.3 to 0.5% of the cases, while presence of left SVC is found in conjunction of the congenital heart disease in 3 to 10% of the cases. The presence of left SVC is chiefly from the failure of the involution from the left cardinal vein. The left SVC usually drain into roof coronary sinus into the rare in 90 to 95% of the cases, and rest of the cases in drain into the alley. And identification of TE, identification of LSVC in TE is the dilated coronary sinus. Here you see the coronary sinus is dilated, and you see the reversal of the vein flow, venous flow from the left to right, suggestive of the presence of the left SVC. Thank you.